College. He is one of the first to oppose herd immunity. He has helped New York City to simulate the COVID-19 spread. Without further ado, I will pass it over to Dr. Samir.
Thank you all. I just need to figure out how to share my screen. Let me do that now. I think you can see my screen more or less, right? Is that fine?
Mm-hmm.
Great. So happy for me to start here?
Yes.
Great. So yeah, thanks for having me on. I'm Samir Bhatt, Senior Lecturer at Imperial College London, Professor of Machine Learning Public Health at the University of Copenhagen. I'm just going to talk today about aspects of modeling COVID-19. Now, this is a bit of a mishmash of many different parts. And from someone in the audience, I think all I want you to get is a flavor for how this modeling proceeds and how this modeling is done. So, I mean, it's important to have some context, although for a disease like SARS-CoV-2 and COVID-19, that is really, everyone knows about it. We've been living in it for the last year. So it's a new outbreak, and it is unprecedented, right? It's not akin to the swine flu pandemics or other infectious disease outbreaks through the 20th century. It really is unprecedented and exists in this modern age. And only recently, therapeutics and vaccines have really come onto the scene. So for quite a large period of time, there was really no treatment until dexamethasone came on the scene. And now, of course, the amazing effort by scientists to produce vaccines. Now, early on, there was this initial choice because really it was such an unprecedented disease that how to control it was a little bit unknown. So there was an initial choice between what's called mitigation or containment. Now, mitigation was simply trying to prevent an overwhelming of health systems, and containment was more of what sort of New Zealand went for, which was aiming for zero COVID. And the idea behind that was, of course, mitigation was building up sufficient herd immunity while trying to sort of mitigate any costs, and containment was ending for zero. Now, it was clear early on that as the infection fatality rate really was quite high, that a third wave began to emerge. And the third wave was with interventions. And so first starting on this talk was what happened. And that's what we really started doing as a team when we got into this in February last year. And the case for doing this is from statistical modeling. And the reason we need statistical modeling is the data is really sparse and confounded. Data needs to be synthesized. So you don't have just one metric or one measure. You need to synthesize data and account for missing data. And counterfactuals are extremely interesting and illuminating. Now, for those who don't know much about statistical modeling, or the way that these things are done scientifically, there really are two cultures. And I think this was epitomized in a wonderful paper by Leo Bremen about statistical modeling, the difference between two cultures. Now you have, sort of two possible ends of the spectrum. One could be something like a pendulum, where you have a series of mathematical equations that that you can write down, that you can solve, either closed form or numerically, that really sort of explain the evolution of it over time. And on the other end, you have what's really been driving lots of machine learning these days, which is, by the way, sorry for the tapping noise, there's a construction outside, from the machine learning community, which is you specify some class or huge set of functions from which you try to pick the best function while minimizing the amount of overfitting. So you're not sort of trying to fit to the noise, you're trying to get the signal from the data. Now, in the pendulum case, you know everything about the system, and so you can really understand a whole lot of the causal mechanisms or associative mechanisms really well, but you probably can't fit the data as well as you want if there are some complexities. On the other end, with the machine learning approach, that's the Gaussian process, for example, you can fit anything, provably. But of course, you don't understand that much about it. And so one of the earliest papers on this, which was trying to do for infectious diseases what the equations for the pendulum did for physics in the pendulum, is of course the seminal work of Kermack and McKendrick, which developed these SIR models or SEIR models and dynamical systems. Now, along the same time, of course, and this was 1948, the seminal work by Richard Bellman and Theodore Harris, there are a whole series of other ways to do this. So you could do this using these differential equations or governing equations. On the other end, Bellman, Harris, and others said, well, all right, this is a really complicated phenomenon. Let's think of it as some stochastic process or some random process, which is governed by some simple rules. And then let's see how this evolves over time. So it's not, the full machine learning bit where you don't know anything about the function apart from the function space. And it's not the pendulum where you know all the equations. There's somewhere in between. And this is actually the approach we use. And the work on it can be from people in a physics background who want to look at it. You can think of it as just one particle splitting into several other particles, splitting into several other particles in terms of a nuclear chain reaction and fission. And it's about the same mechanism for infectious diseases, except there's a certain time lag between when the particle splits or the person infects. And this is, of course, what's known epidemiologically as the incubation period. So we've early on, we did a paper deriving this age-dependent branching process that's currently under revision. And that, for anyone in the audience that really wants to understand the deep maths behind it, that can go in there. Now, there is a third. There are so many ways about this, of looking at how to model infectious disease. And I'm just going to give you a whirlwind tour of them so that, if you want to start picking up the literature on this, you can go right to the start and move onward. So another example is what's called self-exciting processes. These are now stochastic processes that have another set of governing equations and sort of sit in between that continuum that I described before. And of course, the work follows from 1971 paper by Alan Hawkes, which was used to model earthquakes. But again, it's the same idea where you have an infection that occurs, and then that can cause further infections. And this concept of multiplicative risk will follow rather further on when I give you some other talks. So what is beautiful and what is, for the mathematicians in the audience, a very interesting aspect to look at is that many of these processes are actually the same. So equivalences abound, and this seems like a reasonable way to model infections. So for example, an SEIR model is equivalent to a Hawkes process when you take the expected value of the Hawkes process. The Bellman-Harris process is equivalent to the Hawkes process when you look at the expected value of the two of them. And so there's a lot of these equivalences between them. Now, so let's say now I've given you 3 or 4 different approaches to model infections, right? Where COVID-19, SARS-CoV-2 infections that result in some disease. That's all we need, right? One would hope. We've got a series of governing equations, but there are a whole host of really difficult questions to answer before we can just go into that. And this is why modeling of infectious diseases is so challenging, and it isn't just as simple as fitting a curve to it. Because what data do we use? Number one, it's always noisy data. What are the epidemiological distributions like? All of these are very, very important questions. And so a simple example of why COVID-19 is hard is, what do the epidemiological distributions look like? I've given you 2 things there. Number one is, if I think that, as early on in the COVID-19 pandemic, there wasn't very much testing, particularly in the UK. The UK stopped testing in the general population, barely started, and started just testing in hospitalizations. And so you can't really use case data to model the first wave. It's too unreliable, too confounded, and too noisy. Death data is somberly more reliable, but of course you then need to connect infections to death. And to connect infections to death, you need to know what's the average number of time that passes until someone dies when they get symptoms. And so, we need to establish this distribution from hospitalization data. Another one, which is of course a lot more contentious, is the infection fatality rate. And this is why when sort of people talk about herd immunity and other factors, it really needs to follow from these fundamental facts or fundamental truths that we establish early on, and then through the process of science strengthen that the infection fatality rate for COVID-19 was around 1% in developed countries at the first wave, and that's progressively got better as time has gone by due to treatments, oxygen therapy, non-invasive respirators, and other factors. But understanding these fundamental distributions is important. Now, if you're from a physics background or a chemistry background, you can think of these distributions as fundamental constants. You need them in your model. And so let's just take a really simple model. For those who don't like modeling, just ignore it. Let's say that we don't trust which we don't, in the UK, we don't trust infections. Say we trust the deaths, because when deaths are recorded, the test occurs. There's still problems in the UK, but it's a lot more reliable. So let's do the classic mathematical thing and say, let's connect infections to deaths by some mechanism. And so we say the deaths are some infection fatality rate, that's a fundamental constant, times the infections today, times the probability of dying today. Infections yesterday, probability of dying yesterday. And so we do this in a mathematical model, and using the death data, so that's the plot there on the right with the black bars, we fit to it, we get a pretty good fit, that's the red curve, and then we infer this unknown latent number of infections, which is the blue curve. And this was really important early on because we had no idea how many people had been infected at the time. You know, there was a huge debate early on in around April, May last year about whether everybody in the UK had been infected or almost everyone in the UK had been infected or very few had. This was before we had serological studies that would tell us the truth, you know, scientifically. And so this was a means to sort of go and back calculate when the infections occurred, etc. We also see from this, if you put the purple line down, you can see how lockdown coincides very nicely with infections, but of course doesn't coincide very much with deaths. A rather obvious fact that is missed sometimes. But the key thing that we're missing in that previous model is we need to connect this ultimately to the rate of transmission. Now, this is now very much in the public mind as the R number. How many people does an individual infect on average? That's what we want to know. And so looking at our simplest modeling framework, let's put this together and let me talk you through the process that we did early on in our modeling framework, which is now far more complex, and my colleagues and I now integrate lots and lots of different data. But let's just imagine for the set of this talk that all we are looking at is COVID-19 deaths. So we have the red box, observed deaths. Into this, we need to model some deaths, right? So we need to model some deaths. Now let's start again from the bottom. We say that there are a bunch of interventions that can change transmission, mitigate transmission, that can slow things down, things like lockdown, school closing, etc. These have an impact on the time varying reproduction number, the R number, you know, the number of people being infected. We then put this into our green box, which were all those beautiful mathematical frameworks I showed you earlier. Then, because we have infections, we take our fundamental constants and we know how to then get deaths, because of course, when you have an infection, there's a certain probability of having a death. We look at all these fundamental constants and we model the infections to deaths. And then we connect all of this using Bayesian statistics, using amazing software packages like Stan, etc. And we calibrate this to observed deaths. So relatively simple-ish framework. Now, the difficulty here is that interventions, they all occurred on top of each other. If you look at the UK, right at the end of this plot, you can see that the banning of public events and lockdown occurred on the same day. And you see similar patterns like this all over the place, for example, in Denmark and other interventions in places. So from a statistical perspective, there's no way that you can know, just by looking at the UK data, whether it was lockdown or banning of public events that reduced transmission. And so what we did was we did an approach called pooling, which was big approach and very popular approach from the social sciences, which is yes, I don't know when lockdown occurred. I know that lockdown and public events happen on the same day in the UK, but it did not happen on the same day in every country. And so looking at these different pairings in different countries and doing some partial pooling, what we found in our initial work was that when looking across all European countries, lockdown seemed to have a very big identifiable effect, whereas the other interventions we couldn't get a signal from them. Now, there's many caveats here, right? Did lockdown, does this mean that lockdown was the only intervention that works? Absolutely not, right? All NPIs work. This was just saying that when looking across all these different countries, this is how we got a consistent signal. And you can see this from the blue lines in these various intervention plots for each country. For example, let's focus on the blue lines for lockdown public events in the UK. You can see that the blue line is exactly the same for lockdown and public events in the UK because they happen on the same day. But when you do pooling, meta-analysis, partial pooling, and what we actually did in our paper, you find this observed signal. Now, does this mean that other interventions worked Absolutely not. I have to state that again. Obviously not. That's not what we said in our paper. That's not an interpretation of it. It meant that the most consistent signal we found was lockdown. Now, I wasn't surprised by this because, ultimately lockdown is preventing people from mixing, which is preventing particles from spreading. But this was hugely controversial. And so now we've moved on and looked at other corroborating evidence. Let's say that we found that pattern and people dismissed that. Well, let's move away from any coronavirus data and just look at the timing of interventions against mobility, right? So we see that mobility is another proxy for transmission. We again see the big impact for lockdown being high and slightly bigger now, tantalizing. We're starting to get more closer to the thing. We start being a bigger effect for schools and universities and other factors as well coming in. But of course, lockdown being the bigly identifiable one. And this doesn't change when you lag the timing of interventions. So it's very specific to the timing of when the intervention occurs. Recent work with some wonderful collaborators in Oxford and another paper that built on our model and published in another journal looked at this from a much bigger perspective with lots and lots of conditions. And here you see that the lockdown order is actually much less. But this is what happens now when we get to more stratifying of, what are the interventions that actually start driving transmission, right? Gatherings, banning gatherings, businesses, not essential. And we're still moving on to try to get as best answers we can. We're doing subnational analysis now, and we hope to have results which kind of give us the definitive toolbox that can be used for governments doing interventions. Because, there's a lot of not being said out there that, we knew what to do, we just didn't do it. And to some degree that's true, but it really is just a gross oversimplification of how hard this is, right? We don't know the exact toolbox specific to the UK of what works. We don't know the exact effect sizes. We don't know how these are modulated by behavior. And that's where we come on to the next thing, right? Which is all these interventions are good, but ultimately, one of the failings that we had in our model was that we didn't explain Sweden very well. And we've written a commentary on that after the fact that doesn't change our results, but ultimately is a truth. And behavioral changes can drastically reduce transmission. This is something we all missed very early on in the pandemic, which is how much voluntary behavior can make a difference and how much this is mitigated by, obviously, you can't change behavioral practices or you can't impose, NPI practices unless your government can actually support these, right? If you're in a low and middle income country, it's not equitable to assume that lockdown will work perfectly when nobody can actually adhere to the lockdown because people have to go to work. And so the question is then, do countries need to lock down? Wouldn't mobility be much better? What if we looked at behavior? How do we move aside from what countries did to try to capture this behavior agnostically, and using this agnostic behavior, maybe see what the UK could have done or should have done? And so, of course, the pariah in all of this, of course, has been Sweden. And I hope that this has been dismissed now because Sweden is very much in line with all other countries in terms of suffering this second wave in Europe. But, there was this perception early on that I really want to dismiss just by data, which was that Sweden did nothing and Norway and Denmark locked down, and yet Sweden achieved the same thing, right? This is, as always, a gross oversimplified fallacy that's more political statement than scientific fact. Sweden did a lot. This has been acknowledged by the Swedish health ministers themselves. And they achieved by around April or May, roughly the same metrics as Denmark and Norway, their Scandinavian neighbors that had much stronger interventions. And you see this from people avoiding crowded spaces, from improved hygiene, from people who are going to work. These are surveys done by YouGov, very reputable pollster. And you see this in the mobility data as well, mirroring YouGov. What you do see is that Sweden took longer to do it. Now we know now for the first wave, all countries control their epidemics, so it was possible. But what would be the impact if the UK took the Swedish approach or Sweden took Denmark's approach? And so this is the question which we sought to answer, which is, how can we make this as robust as possible, but also as fair as possible? Because, I really don't go in for this whole politicization and polarization thing. I don't want to be blaming countries. I just want to try to understand what these differences would have meant, just without putting in as many prior assumptions as possible. Now, all of the work I've shown up to this point is putting in a ton of prior assumptions because I need to collect interventions, or I need to collect mobility data, or I need to collect behavioral data. And then it becomes very much a question of what I've included, what I haven't included. How do we do this from a mathematical framework as simple as possible so everyone understands it, but also as robust as possible? And now we move to the other complete extreme, which I had shown all the way in my first slide, which was using the machine learning type approach. So my favorite objects in this world are these stochastic processes, things like Gaussian processes, which are random processes that can basically fit any data to any arbitrary level of precision, but you want to trade off overfitting and underfitting. So we can use awesome things like random walk processes, autoregressive processes. For those more mathematically minded in the audience, these are Gaussian processes, obviously. And so what we can, instead of using interventions and these other things, let us use random processes that we are agnostic to, but will capture the dynamics in our system. Let us also update all these fundamental constants using newest data, etc. But also, let's use better data to understand the first wave, right? When we did the first wave, look at that plot there. We used those pink-brown points, which was the UK death data as date reported. The actual data of date of death is the blue data. So, better data gives you better models moving forward. So what we did was we got better models, did better distributions, and used random walk processes. And so using this minimal assumption model, we get these results when fitting. Now, the y-axis is extremely important to understand. It's the reproduction number, the R number. For those who don't know, it's the average number of people I would infect if I was infected, which means an R number of 3 means I would have infected 3, an R number of 5 means I would have infected 5. And what you will see as we move on from all of this is that Denmark, Sweden, and UK don't look different at all, do they? If I gave you these 3 plots and I made you look at them, I'm sure as you stared at them instantly, you'd have been like, yeah, it's the same thing. They all controlled it the same, which means probably the UK taking Swedish approach would have been pretty good, or Denmark taking Swedish approach would have been pretty good. But this is such a fundamental fallacy, because these numbers, the R number, that number 3 versus that number 5 versus the changes that occur, these are multiplicative. This is not the same as, cancer occurring. This is, if I get infected, I can infect more. And this multiplicative factor is something that appears not to conform to many people's intuitions, but is profound. It's absolutely profound, because multiplicative processes blow up extremely fast, exponentially. And so I have some equations here, but because the audience is not too mathematical, I'm going to just gloss over these equations and just say, how do I do a counterfactual? And a counterfactual means I have fitted this to data. I see this curve for the UK that explains how transmission changed in the UK. It started at around 4.5. Somewhere through mid-March, it started having rapid reductions and ended up at 0. How do I take the Swedish curve and put it there? Well, the simplest thing I could do is just, after March 13th, switch those 2 curves around. And that's what I call the absolute approach. But in this, it's important to see that Denmark, Sweden, and the UK started from different baselines. The UK is a transport hub. And of course, for better or for worse, we didn't, for worse, almost certainly, but we didn't close off transport routes. And the UK higher reproduction number almost certainly reflects seeding from Spain and Italy and other countries that had high infection rates, whereas Denmark and Sweden had less. So right from the start, we can see that Sweden didn't have it as easy as Denmark, but both didn't have it as bad as the UK. That's one thing we can see straight away. And so when we look at the 2 counterfactuals, I'll just read them out to you so you can get them in your mind. The absolute counterfactual is the true course of events until the 13th of March, after which the UK experiences the transmission of Sweden, for example. And the relative is saying, relative to where they started, the same thing. And so in these curves, just to disentangle them, we see blocks for Denmark, blocks for Sweden, blocks for the UK. When you see a line that says abs, Sweden to Denmark, this means Sweden has given its transmission to Denmark, its profile to Denmark. And then you look at these, and now you can discern some differences. But a priori, if you didn't know much about multiplicative processes, you wouldn't have thought too much difference, right? When looking at these, If you look at the Danish curves, you can see that if Sweden got Denmark, everything would have been delayed a lot further down. Now, it's good that we see this because I haven't used any behavioral data here, but this is mirroring the behavioral data that I showed you earlier. Now, if we look at the UK down at the bottom, and we see if the UK took the Swedish approach, it's not huge, right? I mean, you know, if Sweden gave its profile to the UK, so that the UK blocked the first two plots down there in the bottom, you can see some shifts, but you would think that UK probably could have got away with Swedish approach, maybe. But the key here is that transmission means infections, and things are growing multiplicatively. And so these, in the corners there, you can see the actual fit of infections estimated latently. And you can then see the expansions or reductions happened with different mirroring profiles. Now, I realize it's a lot to take in, and you know, I don't want to dwell on too much. So let's just look at the deaths, because that's what's, you know, ultimately important. And let's focus on the UK down at the bottom. Fit to the UK, pretty good. Our model's done a good job. Great. Stochastic processes are wonderful. Now, right next to the fit to the UK, I wish my mouse was working so I could show you, but right next to the UK, you can see Sweden giving the UK its profile, both in absolute and relative. And you can suddenly see this crazy effect where the number of infections is really, really much more. Now, in the absolute approach, it's a little bit more. In the relative approach, you know, factoring in the fact that the UK is a transport hub, it's huge, an absolute huge curve that we haven't even reached now. And so when we look at the absolute numbers in terms of a table, we see this. If the UK took the Swedish approach, you know, the UK experienced 599 deaths per I think 100,000 was it, or a billion, I can't remember. Deaths per million, I believe. 599 deaths per million. If the UK took the Swedish approach, this would have almost doubled up to a factor of 4 in both scenarios. And if Sweden took the Danish approach, they would have reached the same number almost as Denmark, which again conforms to our intuitions. So there are, before I go and see what all of this meant, there are you know, some fundamental assumptions in all this, right? That the demographic and cultural differences between Sweden and the UK would be the same. Now, Sweden, 50% of households in Sweden compared to 30% of households are single person. Now, this means the UK situation would have been probably worse. But then it also means that the UK would have adhered to non-mandatory recommendations as well as Sweden's, which there's no reason to actually think they would, to be fair. You know, that the Swedish welfare state enables people to adhere to recommendations much better than the UK's, at least that's my opinion. But people would have had time to react to these mounting deaths. And it also assumes these epidemiological parameters are roughly correct, and these, of course, need to be improved. And, of course, the infection fatality rate is broadly 0.2 to 1.2. Now, the crazy thing here is that I keep this infection fatality rate, you know, people early on in the pandemic kept saying it was 0.01 to 0.1. And that's above the population fatality rate of many countries. You know, it's higher than the population fatality rate of New Jersey. So, you know, it's been vindicated, but that 0.2 is very low. It's probably unthinkable. So what do we conclude from this? What did we learn from all of this before I open up to some questions? So this is really important. And this is the number one thing which sort of needs to be thought about from a policy perspective. Under conditions of high growth, so lots and lots of, you know, people are infecting other people. And in conditions of high infection prevalence, there are a lot of infections currently there in the population. Small changes in control strategies can really have a dramatic event on the number of deaths that occurred. And so when growth rates and prevalence are lower, you have much more flexibility. And so this has many implications for the UK second wave, which I personally believe follows from all of this, which is, you know, once you let a runaway number of infections go up, it becomes incredibly difficult to control, and tiny changes in your control strategy can result in tens of thousands of deaths. And so the strategy is always not to be reactive, but to be proactive. And while cases are low, to put in interventions then, because the sooner you put in interventions, the lower you get, the sooner you get out. And I think these results essentially conform for people who think in a multiplicative way what should be relatively obvious, that if you have high growth and high infections, tiny changes change everything because of exponential growth. I think my work has shown that lockdowns work, but obviously there are costs, and there will be costs well into the future. But it's a false dichotomy to think that you can have one or the other. And this is really the big problem here. It's that there is no winning here. It's just us against this virus. We still don't know exactly what works, and we hope we will. And if I had to move back in time and advise the UK government before this happened, I would have told them, you know, set up protocols for behavioral surveys so we can have this throughout the pandemic. Because that's key in all of it. So I want to say thanks, and any questions?
Thank you so much for that. Thank you so much, Dr. Samir, for your presentation. I will now dive into the questions. And for the audience, if you have any questions, then please do not hesitate to ask. Okay, so let's start off with the first question. So, is there evidence that this new vaccine will solve the problem, and what are the biggest barriers to its success?
Yeah, so the new vaccine is the only way to solve this problem, in my view. And so I think the vaccine will solve the problem, but people's expectations need to be that this is going to be slow and painful, and it's going to take a long part of this year, and it's just not going to feel like next day we'll go back to normal. It'll be a slow return to normal. The main barriers to its success is uptake. We really need to communicate against anti-vaccine organizations and initiatives about the safety of the vaccine. It is the trials are huge. It is safe. We need to be able to increase uptake, particularly along the populations such as the Black and Indian populations that have reduced uptake now because of pure communication. So the only way out of this is the vaccine. It's not being in lockdown forever. It's the vaccine. It's keeping the vaccine efficacious and ensuring that everyone takes it, because there will be some people who are too frail and can't take the vaccine. And the only way to protect them is just by protecting everybody else. And this is herd immunity.
Thank you so much. I'll now move on to the next question. So you have some really impressive findings and a really interesting use of statistical analysis comparing other countries and differences of prevention measures and their impact. What were your most surprising findings from your research?
I mean, I have to say that there wasn't a whole lot that was surprising, unfortunately. We had to just produce our results with robustness. What was surprising was the amount of negative views towards interventions that have slowed down over time. You know, when we first did this, there was a large number of people who thought non-pharmaceutical interventions don't work as well, at all. That lockdown doesn't work at all. This has been couched a little, but this was one of the most surprising findings. The other one was essentially when I looked at this Swedish counterfactual, and I thought that can't be right. And I'd just fallen into the fallacy that I talked about there, which was not understanding how multiplicative growth and high numbers of infections can just drastically change outcomes, that simply. And so that was also a surprise for me. Yeah.
Thank you. We'll move on to the third question now. As you've pointed out, these are some really important statistical analysis, and they are complex for highly educated yet generic audience. What are your feelings regarding the governmental description of the R value and how they have explained it to the public? And I'll let you, there's two questions within this paragraph, so I'll allow you to.
I mean, I thought it was pretty well communicated, to be fair. I mean, it communicated what the R value is, but the issue here is that, like with any complex phenomenon, no one number summarizes it completely. So you can have an R value that's above 3 and total number of infections being 10, 20. And so people might say, well, the R number is too much cause for alarm. And they'd be right, because they know, you need to look at the R number in tandem with the number of cases and the number of infections currently available out there. So in a sense, the government focusing on one metric, if they had to pick one, epidemiologists use the R number. So they picked the right one, and it makes complete sense, because this would have come from SAGE, from people like me working on SPI-M, to SAGE, to going to the chief medical officer, to being used in government. So it makes sense, but it could be better communicated in terms of what this R means and its multiplicative risk, because this is, people lose faith in it if they see a high R number and they don't see that many infections. They don't understand this nuance that I've just explained now.
So what implications do you think their description of the R value has had on the public's understanding of these?
I mean, yeah, it's a very good question. I wouldn't say I know. I don't think what implications, I wouldn't know what implications it's had in terms of adherence. I think it gives people a binary indicator of when they're in trouble and when they're not, right? You know, when they tell you the R number's above 1, caution needs to be there, right? And so they've communicated this effectively enough that the average Jill would know that the R number above 1 would be, you know, cause for concern because of this multiplicative effect driving. Now, I don't know whether they fully understand the multiplicative effect driving, but at least they understand this binary distinction between this change point at R equals 1 and 0 and 1.
Thank you so much. I'll have a look at the chat to see if there are any questions. So the next question is, what sort of behavioural changes amongst the population would help the country get out of the pandemic?
Well, yeah. So I mean, that's the $1 million question, isn't it? Right? Because if you could just sort that out, you know, it'd be so much easier. But I mean, adherence to the rules is of course one. But you know, I think there's a lot of studies out there that, despite people's views, you know, adherence is pretty decent. I think the reason that infection keeps spreading is that there need to be mechanisms in there for people who can't adhere, people who can't isolate if they're ill, right? If you are having COVID-19 and you have to go to work to support your family and you can't isolate and you're just going to keep spreading that to everybody else, you know, these are the kind of holes that need to be plugged much more than the sort of the other adherence. So in terms of behavioral practices, really, we just need to pull together, stick with it, and you know, from a more personal perspective, I think just help out our fellow person, because you know the public health, the mental health, and other factors of loneliness due to these awful interventions, they are big. You need the interventions, but you know, there are some costs that, you know, we can help just by zooming people from time to time. So you know, behavioral things like that can really help people stick in this for longer and adhere it more. That's just my personal preference, but it's just you know, coming together as a country to get through this, really.
Thank you so much. Thank you so much for this amazing talk, Dr. Samir. And thank you for the insight of fighting COVID-19 from your perspective. Our time is finished now, so our intention is to have a break now, and then if David could kindly introduce the next speaker. David, are you there?
Yes, I'm here. Hi guys. Thank you very much, Dr. Bhatt, for this amazing talk. I think we all learned quite a lot, and what statistics has helped us through this process. We'll take a break from here, and the next talk will start on 3:30, which is about, I'll say, 15 minutes from now. Feel free to leave the meeting and rejoin at the time, and we'll send out a reminder on our Facebook, Twitter, and Instagram. And we are looking forward to see you guys again. Thank you.